This is Cancer Smiles and Sarcasm, and I have Tim Burke here from Community Hospital. So thanks so much for being here.
My pleasure.
Yeah, good. Tim is with the oncology department here at Community Hospital in Grand Junction. He has his BS in psychology and a Master of Social Work from CSU. And CSU is?
Colorado State University.
All right. Woo woo. All right. He has some theoretical perspectives in existential philosophy and phenomenology. And the modalities most used with him in oncology would be acceptance and commitment therapy and cognitive behavior therapy. He's worked it in the community doing lots of mental health stuff. It's pretty impressive stuff what he's done. Traditional outpatient stuff, crisis, co-responder with the police department. And now he's here working as a medical social worker. So in this episode, Tim's going to be an expert in leading us through what everything looks like, right? From your mental health perspective.
Yep.
And some questions that I think most cancer patients have, and then how to find resources like you if an oncology department doesn't have those resources.
Absolutely.
Cool. And so just tell me just briefly about your best moments of your career in general.
I think some of the most important work I did outside of oncology would be when I was co-responder at the police department. Yeah. And it's difficult to say because one thing you didn't mention, I led a program for young people experiencing their first episode of psychosis, which is usually schizophrenia.
Yeah.
But it could have been other things. And so I worked with the young people from 15 to 25 and their families navigating this new diagnosis. So that was fascinating, learning a ton about schizophrenia and having to diagnose dozens upon dozens upon dozens of people with this disorder and all the little nuances that come up with that.
To me, that's the most impressive. I was hoping you were just going to bring that up because that is just like, to me, that would be the most fascinating thing in the world. But
it was really interesting, especially the diagnostic part of it. Interesting what shows up for people that isn't schizophrenia, but looks like schizophrenia.
Oh.
Yeah.
Okay. Like what?
Like trauma.
Oh, okay.
Trauma can show up as a psychotic disorder.
Okay.
There's even people can get so depressed that there's psychotic features to their depression.
Okay. So something that we as cancer patients could be feeling.
Absolutely.
Wow. Okay.
Yeah.
All right. Okay. So moving forward, just so everyone, when we're clear, when I say an oncology cancer patient, I could be referring to anyone who's diagnosed in treatment for cancer or post-treatment, right? Because you deal with all of those people, correct?
Yep,
okay.
Absolutely.
And then a caregiver could be anyone. So any support, friends, families, service providers, etc.
Yep.
So I'll just use those phrases and then you can just kind of answer. If you think should be specific to somebody, then you can just specify that. But for our listeners, that's kind of what we're talking about here. So what are the avenues that a cancer patient might go through to seek mental health through oncology during their journey with cancer?
Well, the most convenient is the services that are within their provider network. So for community hospital, it's myself and my colleague Hannah. All these services are complimentary. People don't get billed for any of the work that we do, any of the one-on-one counseling, the case management, any of that kind of stuff. It's all complimentary. So,
I think that's and it's just kind of a one-stop shop, right?
Yeah.
I mean, we're lucky to be here, and I don't know if you know about other oncology departments, but if everyone has the luxury of this, but also when I found out about you, it was interesting because you also know my history, right? You can consult with my team, right? And
yes.
So, and specific to this is Tammy's cancer world, right?
Absolutely.
And so then you become part of my now cancer family.
Sure.
Really.
Sure. Absolutely.
So
that's right.
So it really is it's different because I used to have therapists, online or wherever you go outside of this, but it's it's a one-stop shop, but you also know my world because my world is different than other people's world, right?
Absolutely. And then too, sometimes I find myself in the role of being an advocate for patients. It's
okay.
Sometimes they'll be like, I kind of wish I would have done this, or I don't feel like they're hearing me, so I'm like, okay, I'll just go talk to them directly and be able to sort of, express those things as a surrogate.
Okay. Okay. Yeah, there you go. Okay. And so based on your knowledge, are people like you available at most oncology departments or?
Yes.
Okay.
Yes. And it's easiest to take advantage of it in the oncology department. Like St. Mary's has their social work team, Huntsman has theirs, UC Health has theirs. But there is also people like out in the community that will specialize in just oncology therapy.
Oh, really?
Yeah, absolutely. So and even in social work, you can be an oncological social worker and get a specification in that.
Oh,
Yeah.
okay.
Yeah.
Who knew?
That's something I'll be working towards.
Okay. Yeah, because I know and actually found out about that, like, when you're going to get massage therapy, there's people who know about ports or lymph node, lymphatic massages and stuff like that, and people so I didn't even realize that there was, like, mental health professionals that specialize
There's
in.
a whole field. It's called Psycho-Oncology.
Really?
Absolutely.
Okay. Hmm. Okay, who knew?
Yeah.
Okay, so if you can find somebody within your oncology department, then you should probably search elsewhere, but look for somebody.
Or if the and one of the best indicators of success in therapy is the relationship between the therapist and the patient. So if someone doesn't feel connected to their social worker or therapist in their oncology department, then find someone outside.
Okay.
Don't feel stuck with that person if you don't feel like you're being heard or you're not making progress. It's really important to be connected with the right person. So if you have to go outside of the oncology department, maybe pay out of pocket, it's worth it.
Okay. Because that's okay, that makes sense because that's who you feel comfortable with, right? So that's who you're
Yeah.
gonna start talking to, and then if you don't feel comfortable there, then
Yeah.
yeah, and if you don't feel like, "Oh, if I just felt like you were just pushing bullshit to me,"
Yeah.
then it's not gonna be successful. Okay, okay. So I wanna talk about palliative care
Mm.
because I hear this, like, you see it all over social media, especially when you're somebody like me with stage 4 cancer. I mean, you hear about palliative care, but you also hear about hospice care.
Yes.
And so tell us the difference between the 2. Explain these things.
So hospice is under the umbrella of palliative care.
Okay.
And interesting, there isn't a palliative care in community hospital or St. Mary's or out in the community. The only place that has one is the VA because technically a palliative care is a team of people working with the patient. So it would be a doctor, a psychiatrist, a pharmacist, case manager, nurses, all these people just specifically for palliative care.
Okay.
And the idea behind palliative care is quality of life, is making things as trying to reduce the suffering as much as possible.
Okay.
While still getting treatment for whatever the disease is. And it doesn't have to be cancer. It can be Parkinson's or even dementia. Those kind of things can qualify for like a palliative care team, even though there really isn't one here in Western Colorado, with the exception of the VA.
Okay.
So,
And when you say all those people working together, it kind of like seem like seamless, right? So it's just like one big team.
and that's all they do is palliative care.
Okay, but palliative care, I still don't get it. Like, what is it?
So it's the idea of reducing suffering, improving quality of life while still getting treatment.
Okay.
And that's what differentiates it, palliative care, from hospice care. Because once you go to hospice, you're no longer getting treatment you're getting treatment for your pain, for all these discomfort and stuff, but you're no longer like getting chemotherapy or getting radiation. Those things stop when you're in hospice
Oh, because you're dying.
because you're dying.
Okay.
And it's usually within 6 months of their projected death.
Okay. So hospice is for the dying and palliative is for the living, kind of.
Well, and people can go on and off because people can be on hospice and start to improve and go back to palliative,
Okay. Okay.
and vice versa. People can be on palliative and get on the hospice, or be on palliative and improve and just be off that team.
Okay. So if I'm saying, okay, I want to get palliative care, but there is no palliative team, what do I do? What am I
So it's a bit of a makeshift thing. So, for example, like our doctors here will be doing palliative care, but it's not technically because it's not a team. But they'll be addressing the same things that a palliative care team would be addressing. So making people as comfortable as possible, working on their quality of life. Like, so do they really need to have this particular treatment? Is it going to cause more, is it going to reduce their quality of life and maybe not improve their outlook so much?
Oh, okay.
So it's just sort of like looking at the odds and doing some math around, like, is this worth it? If there's a doing this particular treatment and there's a 20% chance of improvement, and God, does that person really want to go through all of those things if there's only a 20% chance? And so sort of like that sort of thinking around are the treatments worth it?
Okay. And so are you part of palliative care then?
Not insofar as I'm part of like the social work team. And so somebody who is sort of like in that palliative context from a doctor, and I'll be providing those sort of case management, mental health services.
Okay. Okay. So if somebody like outside of this, I mean, maybe do you know like Huntsman, do they have like palliative teams? Do big oncology departments have palliative teams or no?
Generally, yes, like really big ones,
Okay.
like UC Health. You can still get palliative care, but it just wouldn't be from a team. It would be a bit sort of dispersed.
Okay. So if I'm going to get palliative care, somebody says, hey, you should go get palliative care, and they don't have a palliative team, what do you suggest the first step is then?
You would just go to your doctor, whether it be for you, it'd be the oncologist, and and explain to them what your goals are.
Okay, perfect. What are your goals? That's really what it is, right? It's like, so I really just want to experience life to the fullest, right?
Yeah.
Before I die, or if
Sure.
I've got maybe 5 more years left, right? And so what does my treatment look like?
Yeah. And just kind of weighing all the different options about, like, is this worth the side effects? Is this worth all of the extra effort to go through?
Okay. Gotcha. Okay. And so you and I have briefly brought up this idea of death anxiety.
Yeah.
So talk a little bit about that. What the fuck is death anxiety?
It's fascinating because we all have it.
Okay.
So death anxiety starts off, well, let me back up a little bit. We all have it because of this idea called the terror management theory.
Okay.
And that begins in childhood. When we first realize what death is, like when our goldfish dies and it doesn't come back.
Really?
Or the little bug dies in our jar.
Mm-hmm.
And we start to understand, even as little kids, what death is. And that begins as we get older and grandma dies. And it's like, oh, geez, we start to develop this, what they call terror management. How do we manage our death terror? And it usually, it kind of peaks in late childhood, early adolescence.
Okay.
But we carry that with us all our lives, but it's on a subconscious level for most people. And it can reach sort of like a pathological level. And that would be thanatophobia.
Thanatophobia.
Thanatophobia is an unreasonable fear of death.
Oh, okay.
But we all have it. And I think one of the interesting things is there's like this idea of, so I got a couple of things for you, and tell me what you think a representation of death anxiety would be.
Okay.
So like someone like super religious, someone buying organic fruit, someone having a bunch of kids, someone like doing some crazy mountain climbing, like free soloing, rock climbing stuff, really risky, or someone being a workaholic. Which one of those would be someone with death anxiety?
Oh God. Well, I was thinking one, there was a few of them. So one, I was thinking first right off the top of my head, because this is automatically what I think about religion. And so that's what I think. Because I think religion to me, like I was raised Catholic, but I think religion to me is like, it helps you figure out the answer to what's going to happen when you're dead. That's how I think about it, right? Like it's this comfort zone, right? I don't need to fear death because God is going to come and pick me up and put me on a fluffy cloud, and I'll be in heaven and it'll be okay, right?
Yeah.
So I thought of religion, organic fruit, I could think of that one as death anxiety, right? Like, I heard all this bullshit, like, you're gonna get cancer if you eat all these pathogens or, like, so I thought of that one. And those are the two that I'm thinking of. Yeah.
Well, let's start with your idea about religion, because it is fascinating about how religion ties in with death anxiety. So if we think of a bell curve, and we have atheists and people that are really heavily into their faith on either end of that bell curve.
Yeah. Okay.
The people with those are the people with the least death anxiety, the atheists and the super religious, because their worldviews, their cultures are firm.
Okay.
They're well held.
Okay.
It's
And this is like real. This is real.
is real. This
Okay.
is science.
Okay.
This is science.
Okay.
This isn't opinion.
Okay. Yeah.
And the people that have the most anxiety, that are at the top of that, are the people that are in between, that kind of like, oh, I'm not really atheist, I'm not really thing. Those are the people that have the most death anxiety, are at the top of that bell curve, or in between the atheists and the super religious.
Okay.
There's also this fascinating correlation between self-esteem and death anxiety, and anxiety in general.
Really?
So those people that have a high self-esteem have lower anxiety, lower death anxiety as well.
High self-esteem, lower death anxiety. Okay.
Yeah.
Okay.
And even it even correlates to just general anxiety.
Okay.
People with a high self-esteem, for the most part, have less generalized anxiety than people with low self-esteem.
And I get that because I believe in myself. I have control over what I'm doing, right? And so I can I think maybe, I don't know, that is what it is, but like, I can control kind of what comes out of this, or what death looks like, or what,
Yeah.
maybe. I
Yeah.
don't know.
Yeah.
Oh, okay. Okay. Go ahead.
Well, no,
What
there's
your other examples? Because I'm curious.
okay. Well, so having 12 children, the other one was like free solo climbing and workaholics.
Oh, okay.
So they're all examples of death anxiety.
Avoiding death by working, right? Saving your name and saving a part of you by having those kids, right? So you're leaving that legacy on, so you never really die,
Yeah.
because something keeps on going for you. Okay.
Yeah. And the same, like, people that skydiving, oh, they're just trying to avoid their death anxiety. Well, same with the people that are buying organic fruit. They're just
Yeah.
doing it differently.
Okay. And terror management, that is interesting, because then this is like me, is I'm not a mom, but if I were a mom, I'd be listening to you right now going, holy shit, the way I respond to that first goldfish dying with my child could be the development for their life moving forward on
Yeah.
how they're going to respond.
Putting pressure on new moms everywhere.
Oh, wow. Heck yeah. Oh my God. Like, mom, don't do it. Don't do it. Don't go get another goldfish. Oh my God. Like, what have they done? Oh my God.
Well, yeah.
Yeah. But then, okay, so you say terror management, you learn this by like what? As a young child, right?
Yeah.
But then if you are raised like me, who was raised Catholic, and you deal with that in a religious realm, and then you move on into my world now, where I'm not religious, now I have to learn to manage my terror differently, right? Because it's no longer with the response of religion.
Well, according to the theory,
Okay.
that when our death anxiety is acute, we fall back onto our culture.
Oh, okay. So you go back. Okay. And culture is really what it is, right? Culture is how we manage our terror, kind of.
Well, it's what we fall back on
Okay.
when we feel threatened.
Okay.
Our death anxiety comes up.
Okay.
And there's been they did studies where they did this study with judges where they had them, so they had a set of judges that the measure was how punitive they were for people. And so they had a set of judges that was given this survey that was just innocuous, really didn't mean anything. And then they had a set of judges that they gave this survey, and it was all questions about death and dying and all this stuff. And it turns out that the judges that didn't get the death questions were more lenient than the judges that got the death questions. And that wasn't necessarily because it made them meaner. It just, they fell back on where their culture is, which
Okay.
is kind of this, being a judge, you're going to, feel very strongly about people breaking the law
Mm-hmm.
and those, so they're falling back on those kind of things.
Okay. Okay. Interesting. Okay.
Yeah.
So how else? So I mean, those are ways that death anxiety now shows up, right? So we are all dealing with it.
Whether we know and it's unconscious,
Okay.
it's subconscious.
Okay.
So it's
Okay.
there all the time. It's in
Yeah.
the background. It's like a program running on your computer, but it's just in the back. You
Okay.
don't even know it.
And are there better ways to deal with this? Like, how am I supposed to deal with this? Right? I'm dying all the time. Like, right? I've got my. We all. And I tell this to everyone. Right? We all have our death sentence. Right? Mine just happens to be prominent because somebody, diagnosed me with stage 4 and said, "Hey, it's not curable." Right? But we all have a death sentence
Yeah.
because we're all going to die. But
Yeah.
now, how do we deal with this death anxiety? Is there ways to cope with it or to address it, or should we bring it to the forefront and try and make it try and recognize it?
Yeah. We build our self-esteem.
Oh, there you go. Okay. Okay.
If we can learn to value ourselves, that's like the inverse of that. So it's just, the more we value ourselves, the more that anxiety is going to go down.
Oh, okay. Yeah. And so then we go back to that bell curve then, right? Too. Like also you find your way in whatever moral beliefs, whatever moral guidance you have, right?
Yeah.
And you become firm in that, right? You
As
feel
much as we
steady.
can.
Yeah. Okay. So self-esteem, moral,
Yeah.
religious beliefs. Okay. Huh. Okay. Well, I mean, I think death anxiety, like you brought that up to me and I was just like, what the fuck?
I
Like
know.
this is
It is a trip.
crazy.
It is a trip.
Yeah.
If anybody wants to learn more about it, there's a book called The Worm at the Core,
Okay.
and it explains all of this stuff.
Do you know the author?
Solomon.
Okay. The worm.
I think there's 3 guys that wrote it. And they're the kind of the backers of this terror management theory.
Okay. And just on a side note, because you just brought up a book, so I'm just wondering, are there other resources? I know you recommended a book to me, The Subtle Art of Not Giving a Fuck, which
Yeah.
I love that, right? And I actually just got a T-shirt that said, "A wise woman once said, what the fuck?" and or something like that. It says something like, "I don't give a fuck," or something,
Yeah.
and then lived happily ever after. But what are some other resources that you might have for somebody? And this is, let's differentiate between a person who is a cancer patient or oncology patient, some resources that you think that somebody might want to go to, and then move on to like as a support, as a caregiver support, things like that.
Yeah, I wish there was more support for patients and for caregivers. I'm a huge fan of group. And, you come to our regular group. I also started a men's cancer support group. And the title of that group is called The Unchosen Road. Because a big part of even just doing this kind of work is, being involved in or aware of existentialism. I don't want to go down this off track here because you're asking about resources
Yeah.
and stuff. So taking advantage of groups and whatever therapy you can get. There is so many books. There's so much literature on cancer that it's almost difficult to wade through all of it. So I think it's what appeals to each individual person. And I need to be transparent and honest about this because I don't read a lot of books about cancer.
Yeah. Okay.
Because I try to keep a separation, a boundary between my work life and my personal life. So if I'm working all day in oncology and then go home and read books about cancer, I'm like never leaving work.
Yeah. Yeah.
So real clear boundaries around that. So I have some recommendations and just some basic books, but really I think it was the one I was just looking at. Yeah, the Rocky Mountain Cancer Centers has a really good list of books. So if you just Google Rocky Mountain Cancer Centers, they have like 9 or 10 books and just whatever appeals to people because, it's different for different folks. And I just need to be honest around. I intentionally haven't read a lot of books about cancer.
Okay. Yeah. And so some people, like some people like fiction, some people like nonfiction, I
Yeah.
mean, it is just what it is, I don't like to read books, I listen to them, but, I don't really like to read books. I'm a lawyer, I read all the time, right?
Yeah.
But, I like to read, like, case law, but I hate reading books, but, you know, you God, there was something you just said to me, said that I'll get back to it, but so resources,
There
there's a good one.
there's a couple good podcasts,
This one.
especially this one, number 1 on the list is Cancer Smiles and Sarcasm. For caregivers, the Cancer Caregiver podcast is a good one, and then another podcast called In It Together.
Okay.
Those are ones that people can seek out and get some good stuff from there.
Okay.
And I think also me being kind of new to oncology, I've only been doing this for 6 months, so I haven't been able to sort of collect a good list of resources that people have shared with me that I can keep in my back pocket and make recommendations to other people. It's like, oh, well, somebody found this book helpful. You might find it helpful too.
Yeah. Some of the things that I was thinking about that we learn about grief, and I don't know, somewhere I've heard, like, there's these steps to grief, right? Anger, blah, blah, blah. And then somewhere, I don't know if it was you that told me that or somebody else told me that, but that's all bullshit. But, like, and then, like, it's fucking, like, it's fine. Like, it helps you work through it. You
Yeah.
feel this, you feel that, whatever.
Yeah.
Somebody figured out it's bullshit. Is it really bullshit? Or did you tell me that?
I didn't tell you that, but
Okay.
I've heard that before too.
Okay.
And I also, I'm not a fan of blanket sort of, statements.
Yeah. You're
Like,
supposed
grief
to go.
is this. Grief, if you go through these steps, no. And you've heard this a million times. Everyone grieves differently, and all this kind of
Yeah.
stuff. So, and that's true. Everyone does grieve differently.
Yeah.
So,
Group. You talked about group, and why do you think group? Because groups, like, I mean, I went to them, and I've gone to ours, but they kind of freak me out. They freaked me out, the idea of it. And when you introduced it to me, it was like, hey, if you want to help give back, right?
yeah.
You can go to group. And so talk more about groups and how does that help? And why do you think that people should go to groups?
Well, especially for cancer patients. So a lot of times I advertise group for everyone. I tell all of my patients that, we do these groups, and I don't twist people's arms, but I'm a big fan because, especially for cancer patients, number 1, you're already part of the group.
Oh.
Right? You're
True.
already part of the group.
Yeah.
So for people that are saying, well, I'm not a joiner, I don't like groups, like, you're already in the group.
Mm-hmm. Yeah.
So give that up.
No shit. Okay.
Forget about that. And it's what you just mentioned, what I tell people, it's not what you get out of coming to group, it's what you give.
Okay.
Giving's way more therapeutic than getting.
Mm.
So the other thing that's wonderful is that it's your peers that are in there. It's people going through the same thing. And it's not about war stories and sharing this struggle and that and when and just, downer. It's really about having a shared experience with people. And people don't always want to get their information from people like me. They want to get it from people that have the experience of having cancer. I don't have cancer. I haven't had cancer. I don't know what it's like.
Mm-hmm.
So I can be all clinical, but I can't have that same connection because I haven't been through the same thing.
Okay.
And so that way it's wonderful where I can be there to facilitate the group, but it's more about people's connection in the group. Because you know how I talked about earlier about the connection between the patient and therapist, that's the best indicator of success. It's being able to connect with other people
Okay. Yeah.
in the group.
Okay. And so, like, yeah, because I'm always like, well, you're not dying like me. You don't have what I have, and I can't connect with you, like, but it's not true. You could, but there is something about me that wants to, like, I want to have a stage 4 group cancer, like, but you can still, like, I
For
still
sure.
get something
And
from
it's
it,
like, like back in the day when I used to do substance abuse work, people would say, well, you don't know. I'm only going to go to somebody who's been through it. And it's like, wait a second. God forbid you had diabetes. Would you only go to a doctor that also had diabetes? Come on.
That's funny. Yeah. Seriously.
And the same's true here.
Yeah. And the funny thing, I don't know why I'm thinking this though, but a fat gym teacher. Like, come on, be a role model, dude. Like, why do you look like that? And you're the gym teacher. You're teaching us how to be physically fit and physical education. And look at you. Oh my gosh. My philosophy teacher once said, fat people always park close. That's like all I got from that philosophy class, right? But yeah. Okay. Yeah. So true. Okay. So group. So group is a good resource.
Group's a great resource.
And if nothing else, just to go and maybe get another resource of where you want to go.
Absolutely.
Yeah. And meet a friend, somebody to have a beer with.
It is interesting to see after group is over, and I'll be coming up to my office. So I'll look out the window and see the guys standing in the parking lot shooting a breeze.
Yeah.
After
Nice.
group. Yeah.
It's somebody to talk to. Somebody, beyond your other non-cancer people.
Yeah.
Yeah.
Mm-hmm.
Existentialism. You kind of keep on coming back to that. So talk a little bit about it.
It's a big driver for folks with cancer.
Okay.
And existentialism is really difficult to wrap our heads around because we can go down all kinds of different rabbit holes. But if we think of existentialism as each one of our own responsibilities to find meaning and purpose in our lives.
Okay.
That's basically existentialism in a nutshell.
Okay.
So it is, and it's even harder because we're doing it in this context where there really is no inherent meaning in our culture, in our world, in anything. There is, nothing. So
repeat that again. Repeat what it is again in a nutshell.
In a nutshell, existentialism is each one of our own personal responsibilities to find our meaning and our purpose in our existence.
It's a hard one.
It is super hard.
Yeah.
And we all struggle with it, whether we know it or not, especially because, and so I've learned a lot about existentialism and fascinated by it because I use it in therapy. But it's interesting because I wouldn't call myself an existentialist, but sort of like a student of existentialism.
Okay.
But I'm also a bit of an absurdist. And the absurdism is a branch of philosophy, and the absurdists believe that any attempt to find meaning in anything is an exercise in absurdity.
You're serious? That absurdist is like a thing?
Yeah.
Okay, cool.
Yeah.
Okay.
Yeah. But there's that bit of it too, because I think all too often people are trying to find meaning where there is none.
Mm-hmm.
And what torture that is. And then they just make something up.
And that's why it rears its ugly head so much in oncology.
Yeah.
Okay. Well, it's not really an ugly head. Yeah. It just rears its head. Yeah. Because you're trying to figure out why.
So that's why existential psychology is super important. And I've always been fascinated with it, but have never been able to practice it in any meaningful way.
Okay.
Until now.
Okay.
Because people need to find meaning in their existence when they're faced with this life-threatening thing.
Mm-hmm.
I mean, that's what an existential crisis is.
Yeah.
It's a crisis of existence.
And it's not that you're not saying, do they need to? Like, are you saying for their mental well-being they need to? Or are you saying because people want to?
People, good question. I think it's helpful if people do it.
Okay.
There's those people that just don't go there, right? Just never open up their minds to explore any of that stuff.
Because it's hard. It's hard.
Hard.
And it takes a lot of self-awareness, I would imagine, and, insight into yourself and
precisely
all those things that, I think that most people lack. It's like taking accountability. Most people can't do that, getting out of this entitled, kind of frame of mind thing.
Yeah.
But, okay.
Yeah. And it's like anything else. You're going to get out of it what you put into it.
Mm-hmm. Okay.
So
that's kind of one of the things that you were talking about. That's kind of your framework that you deal
For
with.
sure, because there's like this unchosenness about cancer. That's why I called my group the
Yeah, I
Unchosen
love that.
Road. It's like that's what existentialism is. It's like the unchosenness of life. We didn't choose to be born. We didn't get to choose what family we were born into. We didn't get to choose what country we were born. It's like the original unchosenness.
Ah, yeah.
That's just, it's like the unchosenness of cancer.
Mhm.
People are going along their merry little lives, just oblivious to everything. And then
And
all of
then
a sudden,
bam.
bam, you get this.
Yeah.
And then they thought they were in control. They thought they had their ducks in a row. All of a sudden, this idea of control goes completely out the window
Yeah.
because it's been an illusion the whole time.
Yeah. Hmm. Yeah. All right. And then you got cognitive behavior.
Sure. And that's just a really kind of like tried and true method of having people look at their cognition. So the ABCs, the activating event, how we see that event, and what do we do with it.
Mhm.
And so just skills in being able to get from A to C and sort of like change how we think about things. It's changing our thinking and behavior activation, activating those behaviors that are helpful for us.
Okay. And that's again, that's hard. Changing behaviors is always hard, right? Why don't people go out and get new jobs? Because it's hard, right? It's hard to make that change.
Yeah.
And
And especially if it's because of our cognitions. Whatever people might come up with, sort of like malordered thinking they have about themselves and the world, and that's why they can't change their jobs. And so CBT can help with changing those cognitions,
okay.
reordering them.
CBT, cognitive behavior
Yeah.
therapy.
Mhm.
So, in case those
Yeah.
people who
But more, I
keep
do
moving.
more. I've more more acceptance and commitment therapy is probably the most effective.
Okay. And what is that?
So ACT is evidence-based theory like CBT, and you can break it down with the acceptance bit is accept learning to come to accept the things that we have no control over, which is pretty much everything in my opinion. And then the commitment bit is first focusing down and identifying what our values really are, and then committing to our values in our everyday life.
And those values can change. And
They change, especially when someone gets a cancer diagnosis,
yeah, what's
because
valuable
all of
now?
a sudden, like this idea of, oh, wealth or fame or anything else, those things can go by the wayside when someone
Mhm.
gets a cancer diagnosis. And that's why it's important for, if I'm doing ACT with the patient, that's where we start, is with values
Okay.
and what those are.
Yeah. Yeah. It does change. Yeah, I think about that. The other day we were talking about that. How you want me to listen to things and let people feel how they feel. But like the other day in the car, again, I'm always like, why are you fucking yelling at the person when you're driving? Who cares? Life is too short to get mad about these things. But not everyone's life is too short. Just mine, and so, but, now I value something different versus, what that other person is valuing, and so,
Yes.
yeah, so
Sitting here nodding, shaking my
yes,
head
yes.
in agreement.
He's looking at me like, yes, this is what he does during therapy too. Just looks at me and shakes his head. Yes, 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 yes. All right, one of the other things that comes up, PTSD. Talk about
Yeah.
it. What is it?
Post-traumatic stress disorder.
Okay. And it rears its ugly head in cancer?
It does.
Oh, why?
Well, on a lot of different levels. So people could get diagnosed with PTSD from their cancer experience. Because one of the key components of getting a PTSD diagnosis is either our life needs to be threatened, either actually or in some way our life has to be threatened, or we have to be sexually abused. That's one of the key components of it.
Okay.
So, you can't get a PTSD diagnosis from like cyberbullying unless your life was threatened.
Okay. And some
You
people
know?
might feel like their life
Yeah.
is threatened. It's just that dramatic, but
So yeah, I mean, it shows up for people a lot. And the interesting thing too is how this experience this life-threatening experience can bring up PTSD from earlier in life, because it triggers those things that even if people didn't acknowledge it, that there had been whatever, they had PTSD or could have been diagnosed with PTSD from something that happened early in their childhood. That stuff can get brought right back up to the surface because of this life-threatening event.
Okay.
So, for example, a combat vet who, got diagnosed with PTSD. 10 years later, he gets a cancer diagnosis. All of a sudden, a lot of that stuff comes back up.
And that's what I think of. You think about vets, like people who are in the war, right? That's PTSD, right? And I think about it as foster kids, like a lot of them have PTSD,
Yeah.
But yeah, you don't think about it. Like, and how do you know that? How does it show up for us cancer? Would it be cancer patients or would it be supports?
Well, so technically, I don't think I would give someone a PTSD diagnosis who was a caregiver.
Okay. Because you can't, because you didn't have that life.
They didn't have it. They didn't experience it firsthand.
Yeah. Okay.
Or you can get a PTSD diagnosis, but through the death of a loved one, but it has to be a violent or sudden death. It can't be because of a long drawn out illness.
Oh, okay. Okay. Interesting. Okay.
Yeah. So some of the things that will show up for people, like common symptoms of PTSD: hypervigilance.
Okay.
So and some of these things might not show up for cancer, but like avoidance, heightened startle responses. There's such a long list. Like dissociations, like people will feel like they're having an out of body experience. So yeah, those are just some of the things. You can look, like I even have my Bible of mental disorders here.
He's got his DSM book here.
So I mean, PTSD has like 2 pages of diagnostic criteria to go through.
Okay.
But people can get flashbacks. Yeah, there's just a lot of stuff that can go into PTSD, nightmares, all that kind of stuff.
And every time, like, we go to scans, they call it scanxiety, right? Like, because that's like maybe the first time we got diagnosed, right? And you're like, okay, am I gonna, they're gonna tell me something
so that would be
new today?
Yeah, and that would be the, sort of like a triggering event. That's one of the parts of it too. Like we would avoid those things that would trigger those kind of feelings.
Okay.
Yeah, and then another big part of it too is probably one of the bigger ones, to be honest with you, is intrusive thoughts as a big part of PTSD.
And talk a little bit more about that.
Yeah, so like, for example, cancer patients have them all the time. It's like, oh, they told me I got my diagnosis, I'm cancer free, but I got this pain over here, and now what is that? Intrusive thought. Maybe this is my cancer coming back. Oh my gosh. That would be an example of how PTSD can show up.
Okay.
In cancer patients. Like,
and this is important.
Thoughts.
This is important for not just for patients, but for caregivers, right? Supports, because you want to know, like, this is a trauma that they're dealing with, right? And it's important for you as a support to then recognize, hey, this is what I'm dealing with, and this is how it's showing up, and this is how it's manifesting itself, right?
Absolutely.
And so I want to go back, groups.
Yeah.
Groups for supports, right?
Yeah.
Why is that important?
Well, I think just this idea of having a shared experience.
Yeah. But also, like, here, I would imagine you hear like some of the crazy shit that we do, right? And you go, okay, it's not just my wife that's doing that. It's your wife too.
Yeah.
Because maybe some of these PTSD things, show up for multiple people. And then they're like, oh, wow, okay, yeah, I'm dealing with that at home too. And how can you address that?
Yeah.
Yeah. Okay. Got some great things here. So we talked about resources, but what about like your guidance? How about for patients? What's your 10-cent takeaway? What's your big piece?
And I don't have any original thoughts on this one.
Mm-hmm.
I would just kind of go back to this idea of always have an advocate with you, have someone in the appointments with you that can take notes or record and have a list of questions that you come in before, because a lot of times people will go into their appointment and the doctor starts talking and just blank out.
Charlie Brown. Wah,
Yeah.
wah, wah,
Yeah.
wah, wah.
So having someone to advocate for you and feel empowered to stand up and ask questions, because doctors, they're just gonna, and nothing bad about doctors, but they've got a job to do too. And so they're doing what they think is best, but you might have questions, about like, oh, well, can I, so, it's like, oh, well, I didn't see my scans. Is it really there? Can you show me what this looks like? And so I have I'm a visual learner. I need to look at these things. I can't just hear you tell me this stuff. I need to see it for me to be able to wrap my head around it. So those kind of things, standing up for yourself around just those little things. And the doctor will be happy to do that with you.
Mm-hmm.
So that, like, having a good advocate, not necessarily just being a good patient, and just yes, doctor, yes, doctor. Like,
Yeah.
stand up for yourself. If you have questions, if you don't think something is right, then you need to say something about it. And then taking advantage of all the other supports that you can get. So the social workers and mental health services are great. And doesn't mean that you have to be in therapy for months and months and months. You can just go see someone for one time and feel better. And then, okay, I'll come back and see him again in 6 weeks or whatever, just as things come up for people. Don't feel like, oh, a therapist, they want to dig in my head and kind of like drum up a bunch of old childhood stuff. No, we're more solution focused about what's coming up for people in that moment.
And you get paid to just sit there and look at me and listen to me cry. I mean, I remember the first couple times, right? Like, that's what I do. I just sit there and talk and blah, blah, blah and cry. But like, your husband or your friend or somebody else doesn't want to sit there and listen to you cry. And you're not going to do that maybe with somebody else, right? And so just that free space to just feel however the fuck you want to feel.
Yeah.
Right? And say whatever the fuck you want to say. And you have that.
Yeah.
Right? You are that person, right? You as the social worker, right? And I think we don't recognize, like, I had a physical therapist that did that for me. She was just, that person was just like, hey, you know what? Right now, Tammy, I think you're just having a mental breakdown, and so she just let me vent, and sometimes you have those supports and you don't really realize that they're there,
Yeah.
that you have a big team.
And sometimes when we start this process of like doing therapy for cancer patients, a lot of other stuff comes up for people. You kind of open up those floodgates and a bunch of stuff comes out. So, if there is a bunch of like childhood trauma and that kind of thing, then we'll just refer out and get you hooked up with somebody who's, better, has the better equipped to deal with sort of like maybe someone needs EMDR or something like that.
Yeah. And I didn't touch on this, but I think you are like, you as your social worker, you are there for supports, right? Too. So so a family member could come in and talk with you.
Absolutely.
Okay.
Encourage it.
Okay.
Yeah. And especially caregivers.
And I think that's what maybe they think, hey, I don't have anyone to talk to. I don't have this. No, you do. You have this team too.
Yeah. And take advantage of it. That's what we're here for.
Yeah. Okay. And so that guidance for supports. Any other guidance for supports?
Yeah. Guidance for supports. That's tricky. And the analogy that I like to use is when you are flying and they start to give you those instructions about exits and this is what happens, for in case of an emergency, and they talk about the oxygen masks popping down. And the first thing they tell you is put your oxygen mask on first and then help the person next to you. And that's really key for caregivers. They need to take care of themselves first.
Wow.
And that way they are in the best condition to give care to someone else.
Wow.
Because if they're a wreck and they are burnt out and their tank is just empty, it's hard for them to be a caregiver.
Yeah. God, that was a powerful visual. Thank you for that. That was like, holy cow, didn't think about it that way.
Absolutely.
Wow.
And they have to take care of themselves, and a lot of them don't. That's probably the majority of them. And they are just spent.
And it's so hard. Like, I think about my mom who was doing it, and she was just like, one day I'd like maybe have her on here, but I think it's still too fresh, and she was taking care of my dad. But I didn't even realize, I went to Michigan and I took her out to dinner and she's like, I haven't been out to eat in 3 years. And I thought, what? Like, you're fucking kidding me right now, right?
Yeah.
No, she hadn't because, my dad couldn't go out to eat. And so she was always taking care of him. And wow, but yeah, that visual, God, I can get the visual out of my mind now. That's a powerful visual. Yeah. Put that oxygen tank on you first. Wow.
Yeah. Hard for people to do.
Yeah. Well, and you feel like there's not enough time. There's not enough, but yeah, go see the social worker.
Or feel guilty about it, doing something nice for themselves when, they should be caring for this other person.
Oh, yeah. The other person that's suffering. And so should you be suffering too?
Yeah.
Yeah.
Sort of a self-imposed sort of thing.
Oh, yeah. Interesting. All right. Any other words of wisdom? Any other thoughts you want to leave our listeners with?
No, I wish I had something brilliant to say.
I think you said some pretty brilliant things already. Yeah. Yeah, that was pretty powerful. Cool. Well, how about a joke? Get a joke?
Well, the thing about cancer is it sucks, but it grows on you.
Oh, yes.
So what do you call somebody whose lymphoma just keeps coming back?
I don't know.
A lymphomaniac.
You got some good ones. Nice. All right. Hey, by the way, for all the listeners, I gave him some heads up that he was going to have to tell a joke.
He did.
I did. Yes, I did.
So.
Well, thanks so much for being here, Tim, and for being on this podcast and for everything that you do. And I hope we have many more years with you. And well, hopefully I have many more years in general, but hopefully I'll have you here as a support. I think one of the things that stuck with me too is that you can be an advocate for me or, for people that your patient, you can have your social worker reach out to your doctor and say, hey, she's not dealing with this well. Maybe you could do this.
Yeah.
And that's something I never even thought about,
or they're in a lot more pain than what they describe to you.
There's just so much, you don't think about, and there is just a huge support group. If you want to reach out and find it, and take advantage of those moments. And I think for cancer patients, for cancer supports, I think it really is important that, that people do that. As hard as it might be, that change, that cognitive behavior, right? You don't want to, that's not what you normally would do, but yeah. All right. Well, thank you so much.
It's my pleasure.
Appreciate you.